Good evening. Welcome to another episode of Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist working in Southern Vermont.
And my name is Robert Stack. I'm a licensed alcohol and drug counselor and a licensed mental health counselor. And it's interesting. This is our next to last show. And next week we're going to be talking a little bit more about how people get help and some of the things that we think help people. But tonight we're going to talk about something that is part of the mental health field, but it's not something that people like talking about too much.
Yeah. Well, see, we were kind of nervous about even broaching this one because, we're personality disorders. Personality,
we'll
talk about.
And yet, they interfere. They're very. I had a doctor tell me one time, Axis 1, depression, anxiety, and all that, is how you are. And personality disorders are really about how you relate to others.
Okay.
And so, I was sort of struck by that when we were looking at this and talking about it, that really the personality disorders are not so much about you as a person too much, but really how you interact in society and with other people. And a lot of times we talk about this, we don't know who our audience is. Sometimes we think it's the people we're talking about. Sometimes we think it's family members of folks. And so I think the one thing I would like to start off, if you don't mind, is that when I worked in the hospital, one of the things I worried about was if you talked about personality disorders, it's one of the few diagnoses that is used to call people names. In other words, people will call somebody a narcissist, or somebody would call somebody an antisocial.
And it might have used a little kind of a swear word in there as they're doing
that
too,
right?
Yeah.
And it was a way of putting people down, too. I mean, it was sort of like, and you always want to be careful about self-diagnosis, and you always want to be careful about diagnosing other people, quite frankly. But I don't like the way people sort of call people names by an illness. And it's especially, I think, and I'll stop, but a lot of times personality disorders, you almost want to blame the person for that personality. Like it's their fault. I mean, well, the reason you're a narcissist is blah, blah, blah.
Yeah, or you would say stop being depressed.
Right.
Stop being, well, you might say stop being an addict, but there's unfairness to it.
And also, and I'll just finish up with this, people with personality disorders, it's very difficult for family members. Now, there's lots of different kinds, but if you don't have a grasp that what you're looking at is an illness, you tend to see the behavior, and you begin to associate the behavior with the person. And I think sometimes when you're, just like alcoholism, just like addiction, you have to sometimes separate and recognize, well, what I'm looking at is really an aspect, a symptom of their illness. And it's not them. It's not all of them. It's just a symptom of their illness. So I just want to say that before we go much further, we're going to talk about, we're going to use diagnosis and words, but be really careful about self-diagnosis and be very careful about how you use a diagnosis when you're talking about another person.
Right.
Is that fair?
I think it's fair. And I think, part of the reason why we thought we really should talk about this is, having done work in the hospital and outpatient world as well, and this might just be kind of exaggerating a little bit, but teachers will often talk about sort of 80-20% rule, that sort of 20% of your students will require about 80% of your energy as far as classroom management and the work that you're doing. And I think, well, that doesn't quite approach that point. I think that a lot of times, working with addiction and having done inpatient work, that it really approaches a point where when you get to that level of requiring care, that there appears to be a very sort of high preponderance of folks who struggle with these things we call personality disorders.
Right. And with addiction, a lot, if you read any of the texts, or people will say, it's not fair to make a diagnosis, personality diagnosis, when someone's detox, or when somebody's under the influence of drugs. I mean, it's just, having said that, I think a lot of healthcare professionals, they have a lot of expertise, a lot of knowledge. Take a really good history, and sometimes you can hear the symptoms. I mean, they sort of call out to you. But again, I think you have to, I worked with a really great doctor one time, and Dr. George Lorman, as a matter of fact, and in discussing a case, but later on, years later, he told me about somebody who was in recovery, and they really didn't look that way anymore. In other words, normally a personality diagnosis, we were talking about this earlier, you don't, anyway, you have them for, And yet it looked like this person actually changed their life and changed the way they lived in their life, and maybe it wasn't what they thought. So I do want to say that, you know, some of us have personality disorder traits. We have certain traits, and they never really come to the attention of a doctor or a psychiatrist or someone to make a diagnosis. And people just sort of live with it, and they know that, oh, he has some touch of obsessive compulsive, or you know, something like that. I think that, you know, you always have to be sort of aware that we all have some aspects of personality disorders. Not all of them, but many of us have certain traits.
Yeah. And that's one of the lessons that stuck with me from as early on as medical school, was that a lot of us have these same qualities, and we shouldn't consider ourselves to be different from folks who struggle with various personality styles or illnesses, because we're all sort of on a sort of, it's called the bell curve or a normal distribution, where there is the level of that trait that most people will tend to display, and then there's many fewer people who display a whole lot more of it, and then fewer people who display a whole lot less of it. So I think we can all identify with this sort of thing, knowing that, say, at times when we're not at our best, that we might appear to have a dysfunctional personality style. And you've got to be really careful about diagnosing this, to not, to make sure that you kind of separate out what might be some conditions that don't bring out the best of us.
Right.
Because there was a study done a long time ago about people hospitalized for depression who were given tests around personality disorders. And then they felt that they met the criteria for, this one in particular, for what's called borderline personality disorder. And when they were retested, say 6 months after the depression had gone away, they were found to no longer meet that criteria for that personality disorder. And I think the same thing with our, say for example, opioid addicted people that we work with. Because those are illegal, and there's a certain, there's an outlaw culture and illegality to that, you could see them as criminals because they're breaking the law. But then once they get into treatment, get their addiction under control, they no longer display those traits anymore.
Right.
So while it can be very useful to kind of get an idea of what you need to do, who you're working with, what styles to employ, there is a chance that what appears to be personality disorder up front might, over the course of treatment, not appear to be there.
Thank you.
Yeah.
And now this gives me actually, Nels, Dr. Klosser here is really the expert in this, and I want him to speak to it. So for those of you who really want to hear about personality disorders, they have a way of, what are the symptoms of them? What are the things that people tend to look for personality disorders? And also, like you did earlier, if you could explain the different clusters.
Oh, sure.
I think that'd be
sure.
great.
Yeah,
Go
no,
ahead.
absolutely. And I want to say, too, that we were talking about earlier about sort of being a little nervous about bringing up this topic in the first place. I've gotten more comfortable over time trying to bring up in a non-judgmental way that there are these things called personality disorders, and some of the things you're telling me here make me think about those, and then share that. What do you think about that? Is this something that's been a part of your life as long as you can remember? But even so, I'm always squeamish about using the word disorder.
Right.
So I say personality type or personality style, and then I might kind of work in, we call it disorder, but I'm always, because like you're saying, there's this sort of accusation or name-calling aspect to it that I want to be sure to avoid that.
Yeah. And it tends to focus on the disorder and not the person. But I still think it's worth saying it because, as you know, someone once said, knowledge is power. Right. And I think self-knowledge is incredible. You give somebody a name, you explain it to them, you give them a diagnosis, and you say, and for some people, they actually have a sigh of relief. They go, oh, well, that's it.
Yeah.
And
they know where to go. They know how to proceed from that point. And it's a very powerful thing.
And I hope you go there, and I'm going to stop. But no, but I mean, working with borderlines, we talked about this earlier, and some of them, they do have a high mortality rate when you compare them to other personality disorders. I mean, it's a very sort of difficult disorder.
Right.
But nonetheless, it is something that you can get a handle on. You can go to therapy, you can deal with stuff like cutting, you can begin to understand. not that the symptoms go away, but begin to understand some of the dynamics of the illness. And I think that, to be self-aware, to know what you're dealing with. And it's not, at least I hope it's not like that sense like, well, I'm so fatally flawed. I think that's part of the reason that people give up. They think they see their diagnosis because it's so harming to their relationships with others that they begin to think that I'll never be able to be happy. Or anyway, that's just my 2 cents.
And granted, it's difficult.
Yeah.
So when we look at what the criteria are for personality disorders, one of the things is that they're consistent across different environments. So it's not like I'm one way at work, I'm a different way at school, I'm a different way with family. This is a way I have of interacting with my world, no matter where I am or what I'm doing. And 2, that it's been present pretty well. You see different figures, but anywhere from, say, early teens to mid-teens, as far as the beginning of the development of these sorts of traits that comprise the various personality disorders, you see them as long-standing and pretty firmly fixed as well. And another piece of this as well is that the way it's sort of perceived by the person, we use this term, ego-syntonic, but that it doesn't necessarily cause distress amongst themselves. It's like, this is the way I am, and sort of looking at the world as though the problem is out there, it's not necessarily with me. It's sort of comfortable to relate in this fashion. So somebody who maybe is anxious or depressed might say, I don't like being like this and I want to change, whereas people with various personality disorders or styles, they'll find a setting that maybe works for them better, or these sets of behaviors feel more comfortable for them. And so there's that feature of it as well that sort of sets it apart as almost, what should we say, sort of more fixed aspect of who they are and how they interact.
And I think it's worth, I hope it's all right. You almost have to sometimes consider the environment. You have to consider the childhood. You have to consider what's happened to them. And I remember working with women that were self-harming, and often they had a personality diagnosis. And yet, it was tempting that people would sometimes accuse them of being manipulative, you know what I mean? And I worked with a doctor, and Dr. Abraham, Susan Abraham, and she basically would say, think about it as a coping skill. You know what I mean? Like a survival skill, and it's not necessarily. So if I'm in a hostile environment, if I'm in an environment that for whatever reason is not healthy for my development, but I have needs, and I need to get these needs met. And I think in some ways I've come to be really careful about when I start thinking about symptoms of some personality disorders, only because it's so easy to slip in that idea that they are abusing our relationship in some way.
Just taking advantage of you?
Yeah, or even like a dependent personality diagnosis we were talking about earlier, somebody who always wants somebody else to fix them, someone else to take care of them and stuff like that. Narcissistic personality, someone seems to be full of themselves and they're all this and that, and but behind that is something else.
What helped me early on, because there's this difficulty in working with people with personality disorders.
Right.
And one of the ways that we make diagnoses for a lot of disorders, for example, is like with depression. When I'm sitting with that person, I start to feel sad myself. Or if I'm sitting with someone who is manic and flying high and feeling great and just going 100 miles an hour, I might walk out of there feeling energized and happy myself, and maybe laughing at this, sort of sharing in this whole sense of excitement that they have.
Right.
And that way sort of giving me clues as to, okay, what I think is going on here with the diagnosis. Or with schizophrenia, just feeling like there's this gulf, that there's not a connection that's happening. Quite often with, say, for example, the borderline personality, you find yourself just mad at them, just really angry at that sort of back and forth and inconsistency that it just makes it very hard to relate, and you walk around just, disliking them.
Yeah.
Which makes it really hard to work with somebody. But something that really helped me was one of my teachers telling me that she actually enjoyed working with personality disorders, and in particular the borderline personality. And when you come to a realization that, as you were saying, these are people doing the best they can with the skills that they have in the situation in which they find themselves, then you get to feel a little sense of empathy for them, and maybe sort of you don't take quite so personally the things that are going on in the interaction with them, in the dynamics of their relationship. And that was very helpful to be able to sort of take a distance and then say, oh, you know, this isn't about me, and this is just bringing me into their struggle and their suffering, and I'm feeling that very strongly when working with people's personality.
And you mentioned a term earlier for people who are sort of different. What was the term?
Oh, eccentric.
Yeah, but the one that you used, was it, you called them something else? I'm sorry.
Well, I don't know. Should we?
Oh, boy, it went out of my head. But it was really a non-judgmental word. It was just, it was a word that sort of, it's just that they're different. They act different. I'm sorry, I'm blanking out. We're on live TV. Well, no, but it was really, it was like right on. I mean, you know, because normally when we were talking about it, was schizotypical?
Schizotypal is a type of personality.
Personality. And people who sort of struggle with that, with relationships. And it was some word that you used that just made me think that, you know, they live in their world.
Right.
And they don't come get help. And I remember you were talking about some personalities that they end up by themselves,
right,
because of their trouble with relationships.
Yeah. So maybe it's worth going through the way it's sort of organized or clustered together. So I mean, actually, they call them clusters as far as various types of personality disorders. And the first one, I mean, cluster A, is what you consider sort of eccentric types of personalities.
Okay.
So you might have the paranoid personality type is in there. And this might be sort of distrustful of other people, frequently finding injury or suspicious, frequently lawsuits or conspiracy theories. That sort of a person there is very mistrustful. And as you can imagine, they don't do very well with relationships and often find themselves to be alone.
And you're one that you got to ask yourself, where did that come from?
Right.
I don't think they were born with it.
Well,
go ahead.
Who knows? I mean, everything. And again, it seems like we're just giving this kind of cliche answer all the time.
No, that's okay.
With everybody, but it's the whole nature versus nurture question again. Or if you want to be fancy about it, scientific, we'll talk about genetics and environment.
Yeah.
And of course, we're all born with this set of genes that we get, from mom, from dad, and then we're set with those. And then depending on what happens to us growing up, you can almost look at it as this sort of body I'm born with, this brain, these genes that I'm born with really stay the same. And that depending whatever else happens to me, whether it might be a warm, nurturing upbringing, it might be a chaotic, traumatic upbringing, it might be the fact that I smoke, for example, that those then have an impact on my genes. And depending on whether I'm resilient or vulnerable, I'm either less or more likely than to develop a problem that might be called a disorder.
Okay. I know I distracted you from the clusters. Go ahead, go ahead.
But it's a good point, because there's certain sort of temperaments that in children might have to do with sort of how reactive they are, how adaptable they are, how energetic they might be, that don't necessarily last a lifetime, but oftentimes, depending on the environment, basic experiences they have growing up, that can seem to lead towards certain personality disorders. So again, that's sort of environmental component, what happens to you growing up. And for what we do know, some things are, again, a chaotic upbringing, early loss of a parent, being traumatized, that these are things that seem to accentuate that vulnerability that people might have towards these sorts of problems. But since, so back to the clusters, that A cluster there, we're talking about the paranoid type. Yeah. Then you have this what we call schizoid personality disorder, and this is a person who really doesn't care for social contact. They're quite happy living in their own world. They're not very fluent when they are with other people, and they tend to find themselves working in sort of isolated, routine work settings, like maybe working the midnight shift somewhere, having a task that's rather repetitive, whether it's sort of like a bookkeeping or a post office sort of mail sorting at night. That's the kind of work that those sort of people would be most comfortable. Most comfortable doing.
Before we get in trouble with the post office, please don't. You won't get mail. But we said this earlier. I worked with a client that was obsessive compulsive personality, and he worked in quality control. They loved him.
Right.
I mean, work loved him. I mean, he was really
absolutely great.
And he worked alone. He didn't like talking with people, and he just sort of didn't worry that people would get mad with him when he found errors or flaws in something.
And it's this idea there's a spectrum, right?
Right.
So at one point, I'm like everybody else with that. And then if I have more of that trait, then maybe there are certain jobs that are really good for me.
Right. Now, his problem was that he was also very found fault with himself all the time. And the way he got relief was alcohol, and that's how I got to know him. The only time he sort of could say, I don't care, was when he was drinking.
Right.
The rest of the time, it was always something wrong.
So he was starting to recognize that he was... So a lot of folks will crave a relationship, they'll crave some kind of intimacy, and they'll find it very difficult because of their personality style to be able to actually acquire that, to meet somebody, to impress them.
No, he was very neat drunk, too. Clean shirts, I mean, everything, just very neat, but, couldn't stop me.
Yeah. So you got me to jump ahead
Go ahead,
from
go ahead,
cluster
yeah.
A to
That's
cluster
all right, go
C,
ahead.
right? We could do that because that's fine, because that's actually, and again, what you make me think about here when you talk about sort of obsessive compulsive is again that cluster C, which we call sort of the anxious cluster of personality types, which has the dependent personality disorder, what's called the obsessive compulsive personality disorder as well. And so this, again, obsessive compulsive personality disorder is actually different from obsessive compulsive disorder. So with obsessive compulsive disorder, you might be afraid of germs, the hand washing sort of thing. You might have these compulsions to check things, like your locks, like your stove, and not be able to leave the house because of that. Or hoarders, those tend to be people with this, very difficult to treat type of obsessive compulsive disorder. With the obsessive compulsive personality disorder, you're seeing these same sorts of features where there's a very sort of rigid way of doing things. It has to be done a certain way. And you often see these people as very sort of expert in their work, but very difficult to work with. They're not able to share. They're not able to delegate. It always has to be their way. Nobody else is capable of this. And you often find that they don't have much of a social life because they're so wrapped up in their work, not able to delegate, and it can be very difficult to work with as well. So it's in that case, you might rather have someone with obsessive-compulsive disorder than someone with obsessive-compulsive personality disorder that you want to work with. Then you just sort of set them loose, and they're going to do things the right way, and you want that high attention to detail.
I might have one of those traits, but we'll move on.
Well, which if we're going to talk about our traits, then maybe we're going to get into the B cluster, which is more the dramatic personalities as a rule. And two of the ones that we mentioned already, the borderline personality disorder and the antisocial personality disorder, those are in this cluster, as well as what's called sort of histrionic personality disorder, which is that very dramatic sort of, like an actor. You see somebody, you think they're an actor or actress who's always on. That would be sort of the histrionic personality. A narcissistic personality, right? I mean, you got to wonder who gets in front of the camera and does this kind of thing like this. So we'll leave that one alone.
We'll leave that one alone, right.
But I mean, the one where our work, if you really want to spend some time getting to know about a certain personality style disorder, the borderline personality disorder and the antisocial personality disorder, those are the ones that come to professionals' attention more often than any of these others. The percentages of the cluster A and the cluster C disorders tend to be in the single digits as far as the percentage of the population that might have any of these disorders. But if you look, for example, in a prison population, estimates are 75 to 80% of the inmates in a prison meet the criteria for antisocial personality disorder. When we're working with addicts, you're like, wow, they seem like they have antisocial personality disorder. Right. So learning how to work with those and recognize those is really important in the bulk of psychiatry.
And yet, if you sort of work with people who work with people in prisons, I mean, a lot of people will blame society, will blame poverty. I mean, poverty has the root of a lot of crime and a lot of substance abuse. So, I mean, the thing, I don't know. I didn't mean to go off track on that.
We're on track. We're on track.
No, but you know, it's terrible. I don't like these names. I have to tell you, I really have a hard time with it. Like, you know, in the Soviet Union, when they wanted to go after dissidents, they gave them a psychiatric disorder, and basically they said, if you're against our government, then you must be against.
You must be sick.
You must be sick because you're not all for one, and you're not supporting our government. And as you know, borderline was originally this idea that there was this border area between neurosis and psychosis, right? I mean, you know, and some patients with borderline personality disorder do experience psychotic breaks. But I think in some ways the label is not that helpful. I mean, it's helpful for clinicians because if you use the term, then everybody sort of knows what you're talking about. Yeah. But I don't think it's a good word. I don't like it. I mean, I don't mean to be judgmental. Who the hell am I to not like something?
Because you think about being the borderline of those two things, there's nothing complimentary about that at all.
Not at all. And it has this whole cachet to it almost that is sort of, you know, I don't know if this new manual is going to make any difference. I imagine they'll keep the same labels. But I really like to see it. You talked about this. They talk about severity. Are they going to talk about severity in personality disorder? Are they going to keep talking about traits?
I haven't been excited enough about the new diagnostic statistical manual to read any previews. But I think there's going to be more of in most disorders, rather than this sort of yes, you have it, no, you don't, to put it on a spectrum. So then saying that this thing like personality disorder or depression or substance misuse is going to not be so yes or no or black and white or, you know, dichotomous where you have it or you don't, whether if you have 3 out of 7 versus 4 out of 7 of the criteria. But to put it on a spectrum, so you would say there's this, you know, this thing that we give this name to, and mild, moderate, or severe then will be the new designations for the illness itself. Right.
In the New York Times, they had this article about the new DSM, and they were sort of criticizing, I forget who wrote it, but somebody wrote it, they were criticizing that there wasn't enough biology to it, that we're still, you know, looking at people as people, and we need biological markers for this disease diagnosis, you know, and you know, because we were going to do this show, I was thinking about personality disorder. What marker do you want to look for in biology? You know what I mean? What neurotransmitter out of millions of them, out of billions of them, what combination of people who cut themselves, harm themselves, been traumatized, have very intense relationships, love people very intensely, feel unworthy. I mean, you know what I mean? I can go on, but I would hate to think that they would boil it down to biology. I really would. I mean, I know it sounds naive, maybe.
No, and you have a lot of people who are sort of critical that psychiatry and the DSM are trying to sort of medicalize what's going on. And in that way, seeking out these biological markers or genetic influences in order to say, see, here it is. So, you know, lung cancer is you're able to discern a certain type of cell that's growing out of control. Tuberculosis, you have it down to a certain, you know, the germ that comes from. And so we don't have that yet. We simply don't have that. And it seems to be much more complex. And some people argue, stop going there. We're never going to get to that point of being able to nail it down with that kind of specificness.
Yeah. Now, this has been a very fast half hour. But, you know, and I'm glad we did it. I mean, I think we both sort of agree that we were a little reluctant to talk about it. You know, because it involves labels, it involves people, it involves people who live with other folks and the troubles they have. I guess I would offer to anybody that, you know, if some of what we said, if you have more questions, you know, next week we're going to talk about how to get help, who to reach out to. I think it's helpful to get to know who you are, and if you have an illness, go to a doctor, find out about the symptoms, and learn to adjust.
Yeah, treatments work, which is why next show we want to spend our time talking about what the resources are in community, well, throughout the state, and just for categories of help that one could seek.
So thank you, folks.
Yeah.
Thank you.
Thanks.